Good morning, everybody. Thank you all so much for joining us this morning. Before we get started, we wanted to note just a few housekeeping points. To avoid background noise, all participants will be muted for the duration of the webinar. This webinar will feature a short presentation followed by a live Q&A session. We have some questions already prepared, but if you have additional questions as the webinar continues, please enter them into the questions box, which is located on the right-hand side of your screen if viewing from a computer, or at the bottom of your screen if you are viewing from a phone. If you have any comments or concerns during the webinar, please also enter them into the questions box. We will review and address any immediate needs as they occur. A recording of this webinar will also be emailed to each registrant tomorrow. The recording will also be available on our website, www.namimd.org, for any individuals that were unable to register today. After the webinar, you'll be asked to complete a short survey on the aspects of this webinar you felt were helpful, could be improved, and what you would like to see for future webinars. We plan to continue hosting educational webinars as we plan to continue hosting educational webinars, and we ask that you please fill out the survey to let us know how NAMI Maryland can best support you during this time. Now I'll hand it off to our amazing board member, Gia Greer-McGinnis.
Hello, everyone, and thank you for joining us. I'm Gia Greer-McGinnis, a board member with NAMI Maryland, and I'm happy to be the moderator for today's webinar. An estimated 500,000 people in the U.S. are living with tardive dyskinesia, an adverse neurologic effect that is usually caused by dopamine receptor blocking agents used to treat certain psychiatric disorders such as schizophrenia, major depressive disorder, and bipolar disorder, as well as some neurologic and gastrointestinal disorders. Today's discussion will cover a wide variety of topics, including causes and symptoms of TD, the impact TD can have on your health, and when you should seek medical care. It will also touch on risk factors for TD, how to be screened, and management strategies for those diagnosed with TD. Our speaker this morning is Dr. Leslie Citrome, Clinical Professor of Psychiatry and Behavioral Sciences, New York Medical College. Dr. Citrome is a Clinical Professor of Psychiatry and Behavioral Sciences at New York Medical College in Valhalla, New York. Clinical Professor of Psychiatry at SUNY Upstate Medical University, and Adjunct Clinical Professor of Psychiatry at the Icahn School of Medicine at Mount Sinai in New York, New York. He is a Distinguished Life Fellow of the American Psychiatric Association and a Fellow of the American Society of Clinical Psychopharmacology, where he currently serves as president. In addition to his academic positions, he has a private practice in psychiatry in Pomona, New York, and is a volunteer consultant to the Assertive Community Treatment Team, Mental Health Association of Rockland County. In 2019, he received the New York Medical College Faculty Author Award for first authorship who published in the most open access journals. And in 2018 and 2021 was recognized as the Voluntary Faculty Teacher of the Year, Department of Psychiatry and Behavioral Sciences in the New York Medical College, Westchester Medical Center. Dr. Citrome obtained his medical degree from McGill University Faculty of Medicine in 1983 and his MPH from the Columbia School of Public Health in 1996. His immediate prior position was as the founding director of the Clinical Research and Evaluation Facility at the Nathan S. Kline Institute for Psychiatric Research in Orangeburg, New York, where he worked from 1994 through 2010 and achieved the rank of Professor of Psychiatry at the New York University School of Medicine. Dr. Citrome is currently a consultant in clinical trial design and interpretation. He is a frequent lecturer on the quantitative assessment of clinical trial results, including the metrics of number needed to treat and number needed to harm, and has lectured throughout the Americas, Europe, Asia, and Australia. His main interests include schizophrenia, bipolar disorder, and major depressive disorder. He is author or co-author of over 550 research reports, reviews, and chapters in the scientific literature. Thank you so much for joining us today.
Oh, it's my pleasure. Thank you for the lovely introduction. I haven't heard it said in such detail in a very long time. I like to joke that my mother wrote it. Anyhow, thanks so much for having me here today. Talk about something that's dear to our hearts, and that is how to best manage or understand the treatment of psychiatric disorders and consequences of the treatment. One of the consequences of exposure to antipsychotics could be tardive dyskinesia. It's not rare. So I'm going to take you through my 5 steps to success, the way I put it. And this is how I basically teach about tardive dyskinesia to my colleagues and residents. I'll be taking some of the slides that I routinely show in medical education programs and highlight what you need to know about tardive dyskinesia. My disclosures are such that I have relationships with a large number of different pharmaceutical companies. And that's how I make a living, actually. I consult in the design and interpretation of the clinical trials that are used to develop new agents. As such, I'm also invited to be a speaker for many of the products once they become available commercially. And I also spend a great deal of time with continuing medical education organized by a variety of different medical education companies, such as you may have heard of Medscape, for example. Years and years ago, I bought stocks in pharmaceutical companies, and actually that was a mistake because now I have to constantly put this in my disclosure box, and I would have been better off buying Amazon, I like to joke, or Tesla, but anyway, that's it. I'll have these stocks forever. I can't buy any more or sell them, actually. So there, I'm stuck with them. Royalties, I get a small amount of money from my publishing activities, but it really is quite minor. You can't make a living writing technical books and articles. So let me go over the outline that will follow for the next about 25 minutes. We're going to go over the recognition of TD, the assessment of TD, ways of thinking about reducing the risk of TD. Then once TD is there, what we can do about it, and then the follow-up for the management of tardive dyskinesia. I'll summarize, we'll have plenty of time for questions. First off, let me define some terms for you. Tardive dyskinesia is actually the description that if you look at the words and where they come from, really brings it home. Tardive means late or delayed, and dyskinesia means abnormal movement. So put that together, it's the late onset or delayed onset of abnormal movements. Now, why do I say delayed or late? It's because it occurs after someone has started an antipsychotic medicine, for example, and then many months or years later develop an abnormal movement. It's not overnight. TD was first described actually in the 1950s, about 5 years after the availability of chlorpromazine, thorazine in psychiatry. But actually, TD can be observed with long-term treatment with any agent that blocks dopamine receptors. Antipsychotic agents are the usual way we think of dopamine receptor blocking agents, but there are others used, for example, in the treatment of gastrointestinal disorders, such as metoclopramide or Reglan. I actually took Reglan myself for about a week after some surgery, and it was very helpful to me, but I wouldn't have wanted to take it for longer than that. The product label for Reglan metoclopramide says not to take it for more than 12 weeks because of the risk of tardive dyskinesia. Today, we use second-generation antipsychotics rather than the old agents such as haloperidol or Haldol or chlorpromazine or thorazine. And these new second-generation agents are gentler in terms of motor movements. There's a lower TD risk, but the rates are not zero. Unfortunately, TD can be associated with significant functional impairment and can be socially stigmatizing. TD remains a significant treatment issue. So what do I mean by functional impairment? Well, it could be something like a physical impairment in that someone has difficulty buttoning buttons or tying shoelaces, for example, or spilling food. And there's also the social impairment. If someone is worried about how they appear, they might be more isolative. They may not be participating in community activities as much as before. I've heard a patient tell me that they go shopping at the supermarket at 10 o'clock at night so their neighbors don't see them because they believe that what is happening in their face, that people are going to look at them and comment on them. It could also impair family members in terms of wanting to take their loved one to, let's say, the shopping mall. If everyone is going to look at them, stare at them, point the fingers at them, and so on, because of the visually stigmatizing nature of tardive dyskinesia. So, for example, we've all seen people with tardive dyskinesia, sometimes with really bad mouth movements like that. Very obvious and stigmatizing. Or movement of the upper extremities in a jerky movements, and that can be stigmatizing as well. Thankfully, there are new treatment approaches for persistent tardive dyskinesia. They are approved by the US Food and Drug Administration for this purpose. So tardive dyskinesia consists of involuntary movements. We typically think of the tongue, lips, face, but also the trunk and extremities. We can see grimacing, as I demonstrated, tongue movements, lip smacking, lip puckering, pursing of the lips. Also, excessive eye blinking is also not rare. We can see movements of the fingers. We call this piano playing. This is different from Parkinsonism or drug-induced Parkinsonism, where the movements are rhythmic, 3 to 6 cycles per second. Tardive dyskinesia is arrhythmic, jerky. Unfortunately, some patients have involvement of the muscles used to breathe, and we can hear grunting. There's also some variants of tardive dyskinesia, including tardive dystonia, so a contraction, let's say, of the neck, and tardive akathisia, where the restlessness is very persistent. Now, I did mention other medicines like metoclopramide, Reglan. There's also some antitussive agents, promethazine. So these medicines can be used by outside of psychiatry. They block dopamine receptors and have been associated with tardive dyskinesia. Now, not everyone with tardive dyskinesia is aware that they have it. This is a big puzzle. This was actually explored and studied in Singapore in a state mental hospital. About 600 patients were in that hospital. About 40% actually had tardive dyskinesia. And of those people with tardive dyskinesia, 2/3 were not aware that they had tardive dyskinesia. And I've seen this in my own practice over the years, particularly when working in the state hospital system in New York. I would have patients who would tell me, I don't have any movements, I don't know what you're talking about. And it's quite obvious that they, of course, do have movements, but they don't see it. Everyone else does, family members and friends, staff. The majority of people with SMI in that state hospital in Singapore who have TD would not have sought treatment themselves, but family members will ask for help for them, or clinicians will intervene. This is a particularly hot topic. There's sometimes therapeutic nihilism. Before we had TD treatments, people would say, oh, well, I don't think we should even look for it because there's nothing we can do about it. Now that we have something that can decrease and eliminate TD for some, there are some naysayers who say, well, if they don't complain about it, then why bother treating? Well, here's the rub. We're trying to get patients out of the state hospital into the community. And it's very difficult to reintegrate into the community when you have socially stigmatizing abnormal movements. Very hard. So I say it's imperative to treat, even if someone doesn't have insight into the movements. Other people can see them. Now, when someone has insight and it looks like the TD is kind of mild, why would they be worried about it? It's not mild to them. And they find it terribly uncomfortable and stigmatizing for them. And so I would treat that too. Thousands of patients are left with TD as a legacy of past treatment. It hasn't gone away. Even with the newer second generation agents, even though the risk is lower, TD can still occur. TD, once it happens, once it's started, is often irreversible. Now, the indications for antipsychotics have expanded. It's not just for schizophrenia anymore. It's also for major depressive disorder, for bipolar disorder, and it's used off-label in dementia, for example. Large numbers of people are receiving antipsychotic medicines. Okay, so that's the definition and overview part of the presentation. Let's talk about recognition. Let's talk about how often it can be encountered. In medicine, we do something called meta-analyses, where we put together published studies and try to come up with a better estimate of things. The more studies, the more accurate or precise our estimates will be. So meta-analysis was done of 41 different studies looking at the prevalence rates of tardive dyskinesia. So that's just counting up people and seeing how many have TD. Well, this meta-analysis of 41 studies included close to 12,000 people, average age about 43 years, 2/3 men. And about 80% or so had schizophrenia or a variant. The overall prevalence of TD was about 1 in 4, 25%. The prevalence of TD amongst people taking the newer agents was about 1 out of 5, about 20%. And the ones taking actually first generation agents, it's 1 in 3, 30%. So these are very high numbers. There was some interesting data though on the prevalence of TD in people on newer agents who have never been on older agents. And the prevalence was actually lower, 7%. But I put to you that 7% is not 0%. Plus, if we think through this whole category of people who've only been on second generation antipsychotics, it means they were not diagnosed in the era of first generation agents. They may be younger people. They may not have been exposed to the antipsychotic for a particularly long time yet. And if we look at the risk factors for TD, well, that can answer pretty much everything. The biggest risk factor is how old you are, how long you've been ill, and how long you've been taking the antipsychotic. So people who've only been taking the newer agents are probably younger, probably not ill for as long, and probably have been exposed for a shorter period of time, relatively speaking, to the antipsychotic. So this is something we need to watch out for in the future, that 7.2% may be artificially low. Now, there are many things that we need to think through before calling what we see as tardive dyskinesia. There's something called spontaneous dyskinesias occurring in the elderly. This was described a very long time ago. It looks just like TD, yet it happens in people who've never been exposed to antipsychotics. This has also been observed in people with schizophrenia. In a very old description by Kreplin in 1907, he describes actually what sounds like TD, but in 1907, there weren't any antipsychotics. So sometimes we would see what looks like TD in people who've never been exposed to antipsychotics. I don't know what we can do about that. We'll probably treat it just like TD in someone with schizophrenia, because today they have been exposed to antipsychotics, and the treatments do seem to work regardless of what we call this. But we will need to differentiate TD from dental problems, denture problems, as well as drug-induced Parkinsonism. So this is a common problem. Is it tardive dyskinesia or is it drug-induced Parkinsonism? They're both treated very differently. With tardive dyskinesia, we know the onset is delayed. With drug-induced Parkinsonism, we know it happens right away. So this is when we observe in people given an antipsychotic immediately or within days or weeks, they have this rhythmic tremor, 3 to 6 cycles per second, or they start to have the shuffling gait. We used to call it the Thorazine shuffle, remember that? So a shuffling gait and some rigidity. Well, people with tardive dyskinesia don't have a shuffling gait or rigidity, so that's a differential point. Now, what happens in terms of giving an antipsychotic? If we increase the dose of an antipsychotic and the movements become worse, well, that's drug-induced Parkinsonism. If the movements look better, well, paradoxically, that's going to be tardive dyskinesia because we're masking the TD with an increase in dose of the antipsychotic. That doesn't work out with drug-induced Parkinsonism. That'll just make the DIP, drug-induced Parkinsonism, worse. What happens if we decrease the dose of the antipsychotic? Well, the drug-induced Parkinsonism will look better, but the TD may look worse. So it's kind of the opposite what happens with TD and drug-induced Parkinsonism. And then lastly, I want to point out, what if we give Benztropine or cogentin? Well, if the person's movements improve, Well, that was drug-induced Parkinsonism, because anticholinergics like cogentin can worsen TD. Now, the treatments for TD and DIP are quite different. Treatment for one may worsen the other. So the new agents that we use to treat tardive dyskinesia, we call them the VMAT2 inhibitors, can actually worsen drug-induced Parkinsonism. And the treatments for drug-induced Parkinsonism, like anticholinergics like Benztropine, can worsen TD. There are other agents that can possibly be used that somehow may be kinder or gentler if someone has both of these, but if there are any questions about that, we can certainly address them later. So my opinion about Benztropine, by the way, is that it's poison. It increases the risk for TD, by the way, and can make TD worse. I've already mentioned it can make TD worse a few times. However, what I didn't talk about yet is that it can impair cognition. If you were to take Benztropine, you wouldn't be able to remember things as well. That's a problem. The patients that I treat with schizophrenia already have impairments with their memory, with their cognition. I certainly don't want to make it worse. And if someone needs Benztropine for a particular reason, I don't want to give it forever. I'm going to avoid prescribing it for the long term. I'm going to think about switching that person to another antipsychotic that will make it possible for me not to use Benztropine. Now, just a warning here, you can't abruptly stop Benztropine. It needs to be tapered off. So we talked about recognition. What about assessment? Well, the standard of care today is the Abnormal Involuntary Movement Scale examination. And this scale has been used by many agencies for routine clinical use, and it's the primary outcome measure for research for medicines for TD. I mention it here, I'm showing you the scale itself, because this is very commonly done and actually helps people in treating patients with TD communicate with each other about the severity of the TD. It allows us to assess for the different dyskinetic movements across different muscle groups and rate its severity on a scale, and helps us also remember to think through, is there a dental problem? Is there another issue here that can explain the movement? And also permits an overall evaluation of severity, as well as measuring impact on function and the level of distress that person is experiencing. It takes about 5 minutes to administer the AIMS, and it really is a standard of care. Now, how often should it be done? It's been recommended to use a structured assessment twice a year for people receiving older agents and once a year for people receiving newer agents, perhaps more often if they are at higher risk for TD, and certainly if they're being treated for TD, they need this done. It's very helpful in order to assess the improvement over time as well. Now, sometimes people use a more informal evaluation, but it includes elements of the AIMS. So harm reduction is the next topic I'd like to address. We want to avoid the occurrence of TD as much as possible. So some of the preventative principles include using conservative maintenance doses of an antipsychotic, use second-generation antipsychotics, but also inform patients and caregivers of risk. Make sure you actually need to prescribe that antipsychotic and assess for the incipient signs of TD regularly. I prefer using a structured examination like the AIMS because it helps me remember to look everywhere and provides a written record of what I've done. Many electronic health record systems include the AIMS, so it is not, pretty standard to encounter it. The risk factors I want to go over again are how old you are and how long have you been exposed to the dopamine receptor blocking agent. So age is really important here. If I gave a 65-year-old an antipsychotic medicine, their risk of developing TD would be much higher than if I gave that same medicine, antipsychotic, to a younger person. How much more common? 10 times more common. So TD emerges much more rapidly in older people. And then the next risk factor is how long have you been exposed to the antipsychotic and at what dose? To a lesser extent, being female, a pre-existing mood disorder, movement problem, and so on can also contribute to risk, but not as much as how old you are and how long you've been taking the medicine. The occurrence of acute drug-induced Parkinsonism can also identify someone at higher risk. In terms of tapering off and discontinuing the antipsychotic, does that help? Well, experiments were done or studies were done looking at people where antipsychotics were tapered off and discontinued. Well, initial worsening of TD was observed in about a third to a half of people. Long-term improvement, again, in a third to half of people. That means it didn't go away for the other half. So it's really uncertain if this strategy would work for the individual person with TD. Someone with schizophrenia, this is not an option. People with schizophrenia require antipsychotics for their lifetime in order to control their symptoms and prevent the risk of relapse of an acute exacerbation. But someone taking an antipsychotic adjunctively to their SSRI or SNRI for the treatment of their depression, well, this is an option and something worth considering. With non-psychotic patients, continuation of the antipsychotic is actually quite difficult to justify. So someone with MDD, major depressive disorder, really hard to say, no, you must continue to take this medicine. We will try to take patients off antipsychotics under those conditions. But someone who has psychosis, schizophrenia, for example, the risk of psychotic relapse is significant without an antipsychotic on board. Which brings us to interventions. What can we do then about the TD if we can't stop the antipsychotic and try that? We have to do something else. Well, that something else is adding another medicine called a VMAT2 inhibitor. So this slide is my only slide about the treatments. There are two, valbenazine and duotetrabenazine, so Ingrezza and Austedo. They're both VMAT2 inhibitors. That's the name that was given to this class of medicines because they inhibit this particular transporter. Vesicular monoamine transporter is the technical term, and by doing so can reduce dyskinetic movements. Both medicines work, and they both work well, and they're both very tolerable. I'm glad to have two options. The clinical trials that tested this included relatively large numbers of people. A variety of doses are available. The durations of the acute studies were quite reasonable, 6 to 12 weeks, and you can anticipate improvement within that time period. These medicines are continued indefinitely, and there are long-term studies also available. Importantly, though, we need to follow up someone who has started on a VMAT2 inhibitor. I call that checking your work. So before treatment is started, I want to make sure there's a baseline assessment and an AIMS, and follow-up assessments using the AIMS. And that way I can see if improvement occurs over time. And if there isn't improvement, I have to ask myself, is there an adherence problem, a drug-drug interaction problem, or maybe that particular medicine doesn't work for that particular individual? Measuring the AIMS dyskinesia items alone is inadequate, of course. I'll need to ask about functional impairments. So this is what I've already went over with the patient and their loved ones. Is there interference with activities such as eating, drinking, speaking, breathing, dressing oneself, writing, working, leisure activities, being with others? And I want to make sure that that improvement also is occurring so that the functional impairments are being addressed. Thankfully, the AIMS contains items that remind us to ask about this, but we need to do a good job about making sure we address specifically what has bothered that individual before and whether improvements have occurred. So let me summarize and we'll open up for questions. I tell clinicians to assume that TD exists in their practice. It's still common and will continue to be because of the increasing use of antipsychotic medicines. I try to prevent TD as much as possible with harm reduction. I'll use medicines that have a lower risk of drug-induced Parkinsonism. I'll use medicines that allow me to avoid using anticholinergic medicines like cogentin. I will screen with the AIMS examination, especially in the older population, and I'll treat TD as quickly as possible after it appears. We have reliable, effective, and now very well tolerated treatments. There are 2 approved treatments, as I mentioned before. Both are efficacious and tolerable. They do differ a little bit in how often they're given, once a day versus twice a day, how we titrate them to the target doses. One of them needs food, take with food versus take any time of day. They have some differences in terms of drug-drug interactions, and they have some small differences in terms of contraindications. However, the clinical helpfulness of these treatments is moot if TD goes unrecognized. Happy to take your questions. Here's my email address. If you'd like to email me, that's fine too. I'd be more than happy to address your questions directly with you now.
Well, thank you so much for providing this important information. Now we would like to move on to our question and answer portion of today's webinar. We have some questions prepared, but we would like to also open up the webinar for any questions the audience may have. Remember that every participant will stay muted to avoid background noise, but you can type your question into the question box at the right-hand side of the screen if viewing from a computer, or at the bottom of the screen if viewing from a phone. If you have a question that you'd like to ask, or if you have a comment about the webinar today, please enter these into the questions box now. If we don't have time to answer each question today, we will provide our contact information at the end of the webinar for anyone who may wish to reach us. And so we do have a couple questions coming in, but I'd like to start by asking you, how does TD affect everyday life, and how does it affect an individual socially and emotionally?
So that's a great question. I've seen people with TD who really have problems dressing themselves, and they wear always t-shirts and flip-flops. And I've always wondered about that. It turns out that it's hard for them to button their buttons and tie shoelaces. And it's really remarkable on how when I get the TD better, I start to see, well, they're wearing shoes now, and they're wearing a shirt with buttons and the collar and so on. And it's because of that functional impairment. Or maybe their clothing was always soiled with food. You know, they put on a clean shirt in the morning, and by lunchtime, it's like they're a mess. And it's because of the inability to hold food still. The thing about TD is that the dyskinesias, the abnormal movements, occur when you voluntarily move other muscles to do other things. So it happens to be worse when you start to talk, when you're walking, when you're trying to do a task, like when you're trying to eat. You may be able to voluntarily move the muscle that you want, but there are other muscles that kind of start to work like by themselves in a jerky kind of way. In the AIMS examination that we do, we use what's called activating maneuvers to bring this out. We ask people to touch their thumb to their fingers, for example, and that's when some movements come out. Or stand up and put the arms in front of them and count backwards from 100, and that's when these fingers start to move. Or when simply walking. When patients walk, we'll see some movements of their hips, perhaps their fingers, and perhaps in their face that they wouldn't have if they were just standing still. So functional impairment is real. And I didn't even address yet, in detail, the socially stigmatizing impairments. So someone who knows they have TD, they go like this, they don't want to be with people who will sit and stare at them. If they are cognizant that they have the TD, they'll shy away from others. They won't get together with family or friends as much anymore. This is particularly the case in people with non-psychotic disorders who have retained insight into the abnormal movement. So someone with major depressive disorder or bipolar disorder who is not psychotic, perfectly insightful. They know very well they're moving their lips or hands and so on, and they feel terrible about it. It's interesting that I've encountered people with schizophrenia who have lost insight, who really never had much insight to begin with. And some of the symptoms of schizophrenia, like a delusion, we know comes with no insight. The definition of a delusion is a fixed false belief that it's unshakable. So you can't have insight by definition there. And there are many people with schizophrenia and TD like this who don't realize they're going like this and who are wondering, why are people staring at me? And then they start to be more isolated because they don't like people staring at them. And then they kind of shy away and don't interact as much. Now, they don't attribute it to going like this, but they realize people are looking at them funny and they don't like it. So that's a degree of insight that I build on. You know, you tell me that people are like looking at you when you're at the mall and staring at you, and like children are pointing their fingers at you. Let's see if this medicine takes that away. And I don't talk about the movement itself because they don't see it, but I talk about other people's reaction to them. And although it doesn't make a whole lot of sense why a medicine would make other people not stare at them, but hey, let's give it a chance.
Great, thank you. And what are some of the associated conditions of TD?
So TD can be associated with some physical problems, like blistering in the mouth. Because if you're moving your teeth and clenching, you're going to have dental problems. You're going to have sores. Dentures never fit, by the way, in someone with TD, and we often blame the dentures, but it could be the TD. So those are physical consequences. Someone with involvement of their diaphragm, they're going to have trouble breathing, catching their breath, speaking may be an effort.
And what are some resources available to support people with TD?
Well, there's actually a growing number of resources. This is the nice thing about having approved treatments for TD. The two companies that manufacture these agents are really trying very hard to provide information to the public about TD. There's a public service announcement type of advertising. There's also direct to consumer drug advertising, but that increases awareness of TD. And both companies have made publicly accessible resources available on the internet. There's also the NIMH that provides resources, and of course, NAMI provides resources about tardive dyskinesia. There's also foundations that have been created to provide additional information about tardive dyskinesia specifically.
Great, thanks. And I'm actually going to grab an audience question. My movement disorder neurologist suspects my TD was caused by a 10-year exposure to Abilify. I've weaned off of that drug. Are there other types of drugs that can boost the effectiveness of my SSRIs without causing TD?
So on label, there is only one other agent that is used in combination with SSRIs for treatment-resistant depression, and that is esketamine nasal spray. The other options to add on to an SSRI or SNRI are all second-generation antipsychotics. In the future, there may be additional FDA-approved agents. Now, off-label, we've used a number of agents to help people with major depressive disorder that isn't adequately treated with one medicine like their SSRI. So we've added other antidepressants, but it's all off-label. We've added lithium, but that's off-label too. We've added thyroid hormone, but that's off-label as well. And those strategies don't necessarily work all that great either. But in the future, hopefully we'll have additional strategies approved by the FDA.
Great, thank you. Our next audience question is, can you recommend any doctors knowledgeable in the treatment of TD in the DC metro area?
Well, that's very specific, but if that person would like to email me, I will email them a link to a network of providers that have agreed to be on that list regarding treatment of tardive dyskinesia.
Okay. And our next question is, can untreated TD symptoms get worse over time, even though a person is no longer taking the medication that caused the TD in the first place?
Yes, this is what drives me crazy about tardive dyskinesia, is its unpredictability. You can discontinue the antipsychotic and the TD is still there, and over time can get worse. Sometimes it gets better. You just never know. It also waxes and wanes, but it never completely goes away. So it's certainly possible to have TD that worsens, gets better, worsens again, even if you're not on an antipsychotic anymore.
And our next question is, my movement disorder neurologist wants me to take Austedo to address my TD symptoms, but Austedo has a black box label warning. It may cause depression and suicidal ideations. Since I live with a major recurring depression and frequently have suicidal ideations, should I be taking Austedo? Are there other medications for treating TD that might be better off for me in my illness?
Yeah, it's a great question. So if you read the product label for Austedo, there is that box bolded warning about suicidality. But the good news is that it does not refer to people with tardive dyskinesia. This box labeled warning is for people receiving Austedo for their Huntington's disease chorea. That's the other indication for Austedo. And people with Huntington's disease have a high risk of depression and suicidality. So this is why the warning is there for them. It does not apply to people who are receiving Austedo for tardive dyskinesia. So perfectly fine to use it for tardive dyskinesia without having that same level of concern as you would have for Huntington's disease. The other VMAT2 inhibitor doesn't have that box bolded warning because that other product, Ingrezza, is not approved for Huntington's disease chorea, so no need for that box bolded warning for that agent.
The next question is, I've had untreated TD for 1 year. I've noticed that my symptoms, face, tongue, lips, hands, and feet, get much worse when I'm stressed, anxious, depressed, upset, or angry. Have there been any studies done on this issue to see if these feelings are a causation or a correlation for increased TD symptoms?
Yeah, TD waxes and wanes. It can become worse with stress. It disappears with sleep. So not uncommon to see, and there's been quite a few descriptive studies that have looked at exactly that.
Great. And the next question is, does the age of onset of antipsychotic use affect the incidence of TD? Many children aged 7 to 15 are being given these drugs for behavioral issues.
So the major risk factor for developing TD is a combination of age and how long you've been on the medicine. So age is independent in terms of risk. So if I mentioned before, if I gave a 65-year-old an antipsychotic, their risk of developing TD would be maybe 10-fold higher than if I gave that same medicine to a 21-year-old. But if I gave that medicine to a 21-year-old and they continued to take it for years and years and years, of course their risk would be higher as well over the years. And when they reach 65, it's pretty likely that I'll see some TD with the older agents. Now, giving antipsychotics to children is a different story. They can get TD, that's for sure, but the risk, it's not the same as giving it to a 65-year-old. But when you're starting early, they may be on that medicine for a longer period of time. I've certainly seen children with tardive dyskinesia been exposed relatively briefly to antipsychotics. So it is a consideration. And if there's options to avoid using antipsychotics, I certainly would consider using them. But sometimes we don't have much of a choice. And it's in terms of risk benefit, it's a hard decision that must be made.
Thank you. Our next question is, please discuss TD and it being irreversible. If it's caught early, can it be reversed, please?
Sometimes. So sometimes we get really lucky, stop the antipsychotic, TD goes away. And I would say that happens in a minority of times, but not an insignificant minority. So it's certainly something that I would try first, particularly when that person doesn't absolutely need to take the antipsychotic. someone with a mood disorder, for example, there are other options that are approved by the FDA to treat that mood disorder. With schizophrenia, we don't have that choice yet. In the future, we might. So in the future, we might have medicines that don't block dopamine receptors that will actually treat hallucinations and delusions. Well, if we have that, then we may be able to avoid TD entirely.
And our next question is, do the functional impairments of TD differ from those of DIP?
Well, actually, they share some common similarities, because if you have a tremor and you can't hold a coffee cup, you're going to spill that coffee. If you have a dyskinetic movement, you're going to spill that coffee. So there's some similarities there. However, it's less stigmatizing to have Parkinson's disease movements in some ways, because you're not going like this. You have a tremor. People are used to seeing tremors. They're used to seeing older people with tremors, the Parkinsonian tremor, and it's readily identifiable. And it's not that dramatic in terms of flailing about. So this is where the TD movements, if they, for example, there's some TD that involve the pelvic musculature. I've actually seen this, and people would be thrusting their pelvis. Now, how stigmatizing is that? So that's where the nature of the movement may make it more stigmatizing with TD. But subtler forms of TD and may be similar to the stigmatizing nature of subtler forms of drug-induced Parkinsonism or Parkinson's disease, for that matter.
The next question is, what is the role of physical exercise in reducing TD in a person living with clinical depression? What about doing mixed martial arts, for example, jiu-jitsu?
Well, if someone is able to do physical exercise, provide their TD doesn't get in the way, and most people can, I think that's good for overall health. I don't know if it would have any effect on the TD itself, but you would be healthier in terms of the cardiovascular system, and you would be healthier in terms of your weight reduction and getting to a healthy weight. So I advocate exercise for everybody and physical activity for everybody. That it has an effect specifically on the dyskinesias, I wouldn't bank on it.
The next question is, I've been working in mental health as a therapist for 10 plus years. I've never heard this information about Cogitin being negative for clients, and often folks I've been working with can't tolerate antipsychotics, mostly first gen, without Cogitin. When does the research begin to reveal this? What research is the main support for this line of thinking?
So Cogentin is Benztropine, which is an anticholinergic medicine. We've known for years that anticholinergics can impact cognition, specifically memory. There have been some experiments done with very strong anticholinergics to look exactly at that issue. And there have been studies looking at patients with schizophrenia who receive anticholinergics and correlating the amount of anticholinergics with their ability or lack thereof in terms of cognitive performance and functional performance. The whole idea of reducing anticholinergic load has been around for quite some time. There's actually now more research being done and more publications, actually in the past year, promoting this notion that anticholinergics are bad. That's why I call Benztropine or Cogentin poison. Frankly, it is. Now, does that mean I never prescribe it? No. If someone has an acute dystonic reaction, their neck goes like this and it's very uncomfortable and painful. It happens after, let's say, immediate exposure to an antipsychotic, let's say haloperidol intramuscularly because they were agitated in the emergency department, and then they go like this. I'll give Cogentin, Benztropine, and I'll continue it until that goes away, but I won't continue it forever. And I'll look for another antipsychotic to use the next time that has less risk for acute dystonia, less risk for drug-induced Parkinsonism. And I avoid the first generation antipsychotics entirely when I have that option. So there are ways of dealing with this, dealing with treatments that avoid drug-induced Parkinsonism and avoid the use of cogentin or Benztropine. Now, a long time ago, there was the idea that we should give everyone who are starting an antipsychotic cogentin, like it's called prophylactic cogentin, and avoid all these problems. Unfortunately, that led to a whole legacy of people receiving anticholinergics for life to their detriment. And if we look back at the original recommendation, it actually wasn't you give cogentin for life. You give it for the first week. And if you don't see any drug-induced Parkinsonism after that time, you stop it. But apparently, that part of the message never got through. So you have very common situations, practice patterns where people are on an anticholinergic for life that is completely unnecessary and harmful.
Thank you. Given the risk of TD, I've been surprised to come across people with Alzheimer's and Tourette's that have been given Haldol. Are the SGA not appropriate for these illnesses?
So in Tourette's, there are some second-generation antipsychotics, at least one, where it is approved for this purpose, but it still blocks dopamine receptors. And given the amount of time that someone will be on this medicine, the risk of TD will still be there. So unfortunately, we need to do something else to treat Tourette's. So actually off-label, the VMAT2 inhibitors have been used for this purpose. It accomplishes what you need in terms of decreasing dopamine signaling. That's the way we look at the mechanism of Tourette's. We want to decrease the signaling of excessive dopamine in some way. VMAT2 inhibitors do that. And since they don't block dopamine receptors, they don't cause TD. So that may be another approach, but it is completely off-label.
And the next question, are treatments for conditions like major depression that do not include oral medications potentially cause TD? Can't remember the name of the treatment, but it's similar to shock treatment therapy.
So there are other treatments for major depressive disorder that are approved by the FDA that are available out there. The ones that come to mind besides electroconvulsive therapy, CT, which by the way would be an excellent topic for another webinar by another expert, because there's a lot of misconceptions about ECT. But putting that aside, there is a transcranial magnetic stimulation that is available out there. There's also esketamine nasal spray treatment out there. Esketamine nasal spray is a medicine approved by the FDA for TRD, treatment-resistant depression. It's a little cumbersome to administer, but it is available, and it's used in combination with someone's standard antidepressant medicine.
Can you talk about TD risk of meds other than APs and Reglan? I have TD partially from Focalin, and I don't see a lot of info on TD risk from antidepressants, stimulants, or allergy meds.
Well, that's because the definition of tardive dyskinesia includes exposure to a dopamine receptor blocking agent. So if what you've been taking does not block dopamine receptors, then it cannot be TD by definition. It's some other movement disorder.
Can you talk at all about the application of repetitive transcranial magnetic stimulation, RTMS, for TD?
So I'm not aware of that line of research, so I don't know. I'd have to look it up.
Thank you. And another question that we have is, how do you care for someone with a loved one with TD?
So for one thing, I want to make sure that they get treatment for their TD, that the prescriber who's taking care of their medicines are aware of the TD and have looked at it and have measured it, hopefully with a structured examination like the AIMS. That's what I would make sure of.
And what are some existing barriers to TD awareness?
So one of the biggest obstacles is the lack of recognition and not knowing that there are treatments for it. And they both go together. So for a long time, there wasn't much incentive to find it because you couldn't do anything about it. Now that we do have treatments for it, well, we're left with, well, how do I look for it? So we need to have education on the distinctive movements of TD and how they differ from other movement disorders. Take away the confusion between TD and drug-induced Parkinsonism, and realize that treatments for drug-induced Parkinsonism can actually worsen TD. Very often I've encountered situations where someone has an abnormal movement, it's not sure what it is, and they just throw some Benztropine at them and thinking, okay, I've done the work, I've treated it, when in fact you haven't. So what really needs to be done is a careful assessment of the movement and differentiating TD from drug-induced Parkinsonism. They're both treated very differently, and treatment for one may worsen the other. I find it's actually a lot easier to take care of drug-induced Parkinsonism. You essentially, you'll need to consider switching the antipsychotic. And if they're on a first-generation antipsychotic, it's actually very logical to switch to a second-generation antipsychotic. If they're already on a second-generation antipsychotic, this was one of the reasons we would switch people over to clozapine, for example. We would select a second-generation antipsychotic that has a less effect on dopamine receptor blockade. And then ultimately, we can take care through change in medicine, change in the dosing strategy, decrease the need for Benztropine or any other anticholinergic medicine. And then we can work on the TD if it's still there.
Thanks. And a final question for today is, how has telehealth changed access to getting help for TD?
So TD is still happening regardless of the public health emergency. And there's a lot of use of telehealth. But by telehealth, I mean visual telehealth. Very hard to assess TD with just a phone conversation with no visual input whatsoever. So if you're just having a conversation over the telephone, it's hard, have you noticed any movements of your lips, tongue, face, arms, legs, and so on? Here, let me talk to your mother, father, sister, brother, husband, wife. Have you noticed your loved one with any abnormal movements in their, in their face and hands and feet and so on? And dependent on the level of insight or ability to observe, I'll get different answers. And then how do I differentiate that from drug-induced Parkinsonism just by description? How do I assess rigidity? How do I assess walking? I can't. However, with visual input, I can. So you can see on the screen my face. I can put out my hands. So already you can see, half my body. And, point the camera down, you can see my feet. I can ask patients to remove their shoes and socks, look at their feet. And I can assess that way. It's a little bit harder to assess how they're walking, but I can ask, someone else in the room to hold the camera for me and ask the person to walk. It's not ideal. I prefer to do this in the office, but if I can't, I'll do my best visually through telehealth.
Well, thank you so much. And I think now I'll turn it over to Danielle for some closing housekeeping items.
Yes, thank you both so much. And thank you to everyone who joined us this morning. And of course, thank you to Dr. Citrome and Gia for volunteering their time for this awesome discussion. Just a reminder, this webinar has been recorded and will be emailed to everybody tomorrow. The webinar will also be uploaded to our website at www.namimd.org for anyone who is unable to register for this webinar today. We hope that it's been very helpful for you this morning. At the end of the webinar, you'll be asked to complete a short survey on the aspects that you thought were helpful, could be improved, and what you would like to see for future webinars. Again, we do plan to continue hosting educational webinars, and this survey will help us determine how we can best support you during this time. Don't forget to join us for our next webinar, this time through the COVID Connect platform, on December 16th, 2021 at 5 p.m. This webinar will cover self-care and mental health during the holidays, presented by August Cheatham. You can learn more, register for this webinar, and view past recordings at covidconnect.health.maryland.gov. For additional resources or support, please visit us at namimd.org or give us a call at 410-884-8691. Thank you all so much and have a great rest of your Monday.